Good afternoon. My name is Todd Streelman, and on behalf of the School of Biological Sciences, I want to welcome you to a town hall discussion titled COVID on Campus Revisited Towards Safe Living and Learning Environments. I'm joined today by Greg Gibson and Joshua Weitz, both Patton Distinguished Chairs and Professors in Biological Sciences, as well as Sally Ng, Professor in Chemical and Biomolecular Engineering and Earth and Atmospheric Sciences. These panelists will present updates to us today related to COVID-19 and this new school year. So before we start, as always, thanks to Jasmine Martin, Assistant to the Chair in Biological Sciences, and Jess Hunt-Ralston, Director of Communications in the College of Sciences, both of whom have helped with broadcasting information about this town hall. My last point is to please put your questions in the Q&A portal and to put comments in the chat. And so we'll address your questions in a Q&A session at the end. This event will be recorded and posted for later retrieval. With that, Greg, let me turn it over to you, please.
Thank you very much, Todd. If I can get this right. Okay. So hopefully that's sharing with you. It's great to be back again. It will be nice to be under different circumstances, but I have to start out today by saying that I'm pretty upbeat about the way things are going on campus already this semester. The trend is in the right direction, or it was yesterday, so we're hoping it's going to keep that way. So thank you to Joshua Weitz for joining us today, actually from Paris, where he's on sabbatical, and thank you to Sally Ng for joining us from California, actually today, where she's also on sabbatical. So my opening statement begins with this question, which is what do we all want, which I think is really to work in a safe, live, learn, work environment, where we're in classrooms with everybody present, professors and students. We have active research spaces. Staff can be confident in their own health. And students can comfortably go to social events, whether it's football games or parties, without needing to worry about contracting COVID-19. We all want that. We just differ in how we can get there. Okay? And we're not quite there yet. Best estimate is we went up to about 2% of students being infected with Delta at the beginning of last week. That seems to have come down to about 1%. There may just be fluctuation, but we're in that range. And it means that the majority of classes with more than 20 or 30 students have had a case in them, and I'll show data on that right at the end. So that's not really safe. If you've got students in a classroom with Delta, infectious Delta, potentially infecting more immunologically at-risk staff, faculty in the classrooms, and then staff in our living spaces. So how do we get to this place that we all want to get to? Well, one model would be to pretend that we're already there and just don't do anything different, let it run its course. Problem with that is it's going to cost us in thousands of cases, potentially up to 5,000 cases, potentially including dozens of hospitalizations of staff and faculty, which none of us want, and even possibly some deaths. And so I think it's incumbent upon us in this day and age to use science to do all we can to limit that. So the second model is to recognize that we do live in a civil society where we respect everybody's rights and we compromise with one another. And that means we have to take reasonable steps to reduce the caseload, particularly over the next few weeks. I do think it's going to come down because history says it will. But we're in a hump and we need to just be vigilant for the next while. We need to have constant testing. We need to wear masks in classroom. And I think the masks maybe will stay around for the rest of the semester, for the foreseeable future. But these aren't terribly burdensome things we need to do to ensure that everybody, as many people as possible on campus, minimize their exposure. Okay, and why aren't we there yet? Well, it's really for three reasons. And one that took everybody's surprise is that Delta is so highly infective. And it may be that there's a new version, Mu, just starting to appear as well, which could be even worse. So, 2 months ago in June, things looked great. Life was sort of getting back to normal, and Delta's just changed the landscape. I think if everybody had been vaccinated, then we wouldn't be where we are today. This Delta wouldn't have gotten a foothold. So that's another issue. And then the third thing, though, now is that on campus, we're just not seeing enough masking and enough social distancing, particularly in classrooms. And so we just need to all of us do what we can to get there. Okay. And what there looks like is minimally, it means positivity below 0.5%. And we got there last year on 3 different occasions, so twice last fall, and then after arrival in late January for the spring semester, and we stayed there. And I really believe that we can get there again, so long as we pay full attention to non-pharmaceutical interventions, so to mask wearing and regular testing, and also being cognizant that if we do engage in risky behaviors, that we test after that to make sure we're not exposing other people should we have been unlucky enough to have contracted this. I need to start with a massive thank you to the surveillance team, which has changed a little bit this year. Some of the key figures have sort of moved on, but Anton Brixen continues to lead and step up and run the testing lab. Samantha Maskuch is the PhD scientist in the lab who every evening, every day is on top of making sure that test results get sent to stamps, and just running things. Greg Hare is a fabulous gentleman that we've hired to run the lab downstairs. And then they're assisted by Lisa and Brian, who prefer not to have their photographs shown, humble as they are, but are doing just tremendous work with the actual PCRs in the lab. Of course, we have Julianne Williamson and Alex Ortiz still doing yeoman's work, just running the logistics, making sure that the different campus surveillance sites are open. And I've listed at the bottom there a number of individuals who are unsung to this point. So Shweta, Naima, and Feng are all involved in sequencing, so we can determine what strains we've got. And then we have Nicole, Amina, Adam, April, Helia, and Maria, among others, a dozen or so others, who are really down in the lab doing the work. And we've been overwhelmed. I've got to say, yesterday, 3,000 tests. We were expecting about 500 a day. So they've just really stepped up. And there's been some delays in getting the reporting right this year, as there were last year. Appreciate your patience with us as we get there. But they're all doing fabulous work, and thanks to them. So just a reminder about the program. We basically have it available for all students, staff, and faculty. Although we think that more than 80%, 85% of the tests are being taken by students, who are the bulk of the population on campus. And there are essentially 3 sources of test. So one is the STAMP Student Health Center, which are rapid antigen tests. It's not quite as sensitive as a PCR test. They can do maximally about 200 a week, and they're seeing between 10 and 15% of the tests that they perform coming up positive for SARS-CoV-2. So the good news in that is that only 1 in 8 of the people who think that they might have it with flu-like symptoms actually do have COVID. So, it's certainly not a sentence of COVID if you think you have it. But the bad news is that there's lots of other infectious disease going around, and that includes flu and mono and all sorts of things, some of which have worse symptoms than COVID for most of the students at any rate. So, actually mask wearing is protecting you as much as anything else from flu and other things. The second source of testing is off-campus tests, and there's various types of those. We don't know how many are performed a week because we only get reports of the positive ones. And I'm very grateful to the people who do test positive, who report to stamps. That's important. And we get up to 10 of those per day. If you look at the dashboard, then that's pretty clear that there's a consistent stream of those. And then, so the good news there is that people are getting tested, off-campus staff and faculty in particular, and they're protecting others by reporting and self-quarantining. Then, of course, we have the surveillance program, which is a PCR-based saliva test we do in our double-pooled surveillance strategy. And we can do about 2,500 to 3,000 a day. And we see between 1% and 2% positives. At the moment, we want to get down to 0.5%. And the good news on that is that we haven't really seen the explosion in caseload that some of us, me in particular, expected last week after the entry parties and things. So we did see a bump. There's no question about it. But we haven't jumped up to the 5% that you will see at UGA. But the bad news is that we're still an order of magnitude really higher than what we need to be to have a safe live, learn, and work environment, or maybe not so much order of magnitude, but we're 5 times higher And I think we can get there. That's what's so positive, right? We're in a similar place we were a few weeks into last semester. We got it under control, and I'm confident we can do it again. So this is just a reminder, there are various testing locations across campus, as well as STAMPS symptomatic testing. The library at the moment is a little bit overwhelmed because it's the most popular central location, so wait times can be 5 minutes or more. We do encourage you to go to the site in Midtown there on 5th, just off 5th. But there are other sites, Connector, and other, there are pop-up sites. So just go to the website, mytest.gartech.edu, to see where the sites are each day that are open. And please, full encouragement for the upper administration for everybody testing as often as they want. It's free and it's easy, and people got into a rhythm last year. We can do it again. Okay, so let's just remind ourselves about what Delta's doing and what masks do. Okay, so if you have a population, suppose that there's a couple of people, so that's 2 in 50 or something. It's really more like 2 in 100 right now. So if nobody's been vaccinated and we don't pay enough attention to masks and social distancing, then we expect that each person is going to transmit this to 2 or 3 others within the space of a few days. And we want to prevent that from happening. So one way, and then if we have the Delta variant, then that is actually at least 50% more. So instead of getting 2 or 3 infections per person, we expect to see 4 or 5 variants per person. And that's the issue with Delta. If we wear masks, it's going to reduce it. I don't know if it'll reduce it that much, but it certainly mitigates things. And remember, masks aren't so much about protecting yourself, although they do to some extent, but they're more about protecting other people if you're positive and you don't realize it, which is very, very often the case, particularly for students and now for vaccinated individuals. Okay, the vaccinated individuals who are positive can spread the virus at just about the same rate as others. So masks mitigate that. If, on the other hand, we have 2/3 of the campus vaccinated, it means that in the original case, only pretty much unprotected people, unvaccinated people would be exposed. So everybody around the person at the bottom there would be healthy, would be safe, and just a few of the people around the ones who are unvaccinated would still be exposed. Delta is going to affect even more of those, although we expect pretty good protection for those who've been vaccinated in blue. And then if you have masks, then that still reduces that more and more. So the combination of masks and vaccines, and if we added social distancing to this as well, is really what keeps us getting us down to a steady state of maybe 1%. And then if you want to reduce it even further, then we use a testing strategy to get people into isolation or quarantine for a week or 10 days while they recover and stop the spread to others on campus. So you might be wondering why it is that almost half the cases on campus that we've observed have been in vaccinated people. And it's just simply a matter of math. Okay, so suppose that 10,000 people test in a week and that 2% of them test positive. Then we can draw a 2x2 table of the vaccination and positivity as follows. So we can have vaccinated and non-vaccinated populations, and we can have the number who test positive, for example. So a typical, so in the last 2 weeks, it's been around about 80 people have tested positive that we know are vaccinated, and about 120 non-vaccinated. These are not actual numbers, they're approximate numbers. But let's suppose that 70% of people on campus were vaccinated, then that would mean that the numbers negative and positive in the 2 groups are as shown there. So about 7,000 tests will be negative for the vaccinated group and about 3,000 negative for the non-vaccinated group. And that would translate into positivities of about 1% or 1.1% for the vaccinated group and about 4% for the non-vaccinated group. Okay. If, on the other hand, 85% of the campus community is vaccinated, which I think I'm pretty confident is the true number. We don't know it exactly because it's not required that people report it. But if that's the case, then those numbers become more like this, more like 8,500 negatives and 1,300 or 1,400 negative in the non-vaccinated, and that creates a much, much larger ratio. So that vaccinated to non-vaccinated would imply that the virus in this case is something like 85, 90%. So the vaccine is about 85 or 90% effective, where it's more like 80% effective in the first case. So we think we are in the purple zone, so we've got a much elevated rate. But the good news is that we're probably actually less than these numbers now. It's more like 1%. So those numbers something like 0.5% and 3 or 4% in the non-vaccinated population. Okay. And if the non-vaccinated are 15% of the Panthers community, then that actually makes up about the same pool size as the vaccinated, who have a much, much lower rate of transmission. So both groups need to test to get us to where we want. Okay, so even though the vaccine is highly effective, the problem is that the much greater number of tests in the vaccinated population means that they make up a relatively larger portion of the positives, and it approaches something like a 50-50 mix, or in this case, a 40-60 mix. If you're wondering why the vaccine is not 100% effective, just a quick little biology on that is because it's really what we call a neutralizing rather than a sterilizing vaccine. So a sterilizing vaccine would be one that removed the pathogen completely before it could do anything. So what this vaccine is doing is neutralizing. So it's preventing illness essentially in those who do get it. So it was designed to prevent severe illness. It does that really well, not perfectly. There are people with the vaccine who get COVID and are hospitalized, but it is doing a remarkably good job at reducing infection and illness. Okay. So the issue is, of course, that the virus initially infects the upper respiratory tract, so the nasal, and that you can detect it in the nose and mouth, and eventually it will work its way down into the lungs, which is where it induces a hyperinflammatory response, which is responsible for a lot of the disease symptoms. It's doing a lot of complex things, but in very severe disease, it's almost like your body is attacking itself, having been induced by the virus. What this virus does, SARS-CoV-2, it has these spike proteins on their surface, indicated by the sort of little brown arrows there. And that protein binds to what are called the ACE2 receptors on the cell membranes of epithelial cells in your airway. What the vaccine does is it actually expresses that spike protein, just the spike protein, not the whole virus. So the RNA leads to expression of the spike protein, and your body is able to make antibodies against that, just as it would against the virus, but it does it before the virus infects. So if you have a large enough titer of antibodies circulating in your blood and eventually in your mucosal lining of your airways, then it can bind to those spike proteins, and it basically neutralizes the virus. It prevents it from being able to bind to the ACE2 receptors and gain entry into the cells. If you have an overload of the virus, just by chance you've got a very heavy exposure, or maybe you didn't produce as much antibody as other people, then it will overwhelm the antibodies and you will get an infection. And so that's what's happening in 10 to 15% of people, that they're not quite able to completely neutralize the virus. It starts to mount an infection. But the good news is that in the few days it takes to get to your lungs, your body is able to re-stimulate your memory B cells to generate more and more of the antibodies and to engage the rest of your immune system, so that by the time it gets to your lungs, you've engaged a full immune response and it will prevent disease. So that's the good news. But the reason why you're getting 10 or 15% of people being positive is just because it's biology. So we just don't all make enough antibody. And the big debate right now is whether or not we'll need booster shots to increase antibody production, and it's looking like that's probably going to be needed, particularly in people over the age of 50 or 60 after about 6 to 8 months. All right, so the final question I want to ask before handing over to Joshua is, do we need a surveillance program this year? So just a reminder, this is data from Conan Zhao in Joshua's group, summarizing the top row is last fall, the middle row is last spring, and the bottom row is our data so far. They're all on the same scale. So we had that big bump in mid-August to 4%, and that came down gradually within 2 or 3 weeks. We were down to 0.5%, and we stayed there until we got that post-Halloween bump again, went up to 2%, and then it quickly came back down to 0.5%. In re-entry in January, we had another bump, got it down over the course of January, and then it stayed down for the rest of the semester. So my hope is that that's the same thing that will happen this year. So what we've seen is a lot of heterogeneity in the levels. So last week we had a bump to 2.5%, which really worried me. But then it seemed to come back down, and I looked at yesterday's numbers. They were just below 1%, but that's on a fairly small sample. So we'll see what happens. But the trend, at least, is that we're not seeing a massive bump. Nevertheless, it's not all, it could go the other way. So if last year's any guide, we can get this under control by late September. But the challenges in doing that are that we have 3 times as many people on campus. We have twice as high density in housing. We have much higher infectiousness of the Delta variant. We don't have a mask mandate, which would really help us to get this under control. And we have thousands of, probably thousands, an unknown number of unvaccinated individuals on campus. In our favor, we have 70%, at least, I think probably closer to 85, 90% vaccination. The initial peak has not been as large as expected, despite the variability that you see there. But most importantly, I think the program is providing peace of mind for a meaningful proportion of our campus community. If you have to go into quarantine for 10 days, it's not the end of the world. And once we're below 1%, it should keep us there. But I just have to remind, and I'm sure Joshua will pick up on this, that faculty and staff are the ones at unreasonably high risk. So we have OSHA rules in place to prevent health exposures, which unfortunately we don't have any control over right now. So you're basically asking faculty who are older than your parents in many cases to go into classrooms knowing that there are positive cases in those classrooms, very often without masks. And so that's the concern that we have on the faculty side. And with that, I'll hand it over to Joshua.
Thanks, Greg. Hopefully we'll pick it up and then hand it over to Sally in a bit. I wanted to provide some more context and then go from broader context, drilling down into the Georgia Tech situation, just to give you some sense that both this has been happening and building for a while in terms of the intensity of risk, and to some extent reflects larger trends. So these are risk maps of the chance that one or more individuals may be infected in groups of about 50 nationwide, and the red is not good. And you can see the red clustered largely in the south and southeast as part of this summer and late summer Delta surge. Unfortunately, it's getting into many places, but certainly in Georgia, Florida, Tennessee, Texas, etc., all throughout Louisiana and the southeast, we're seeing increased cases, therefore increased risk, particularly in indoor settings. Go to the next slide, Greg. And I want to make it very clear that there is a connection between the size of this summer surge, and obviously there are many other cofactors with seasonality, behavior, and so on, as well as the vaccination status and degree of vaccinations. So hopefully you can see in this chart, each one is labeled, that you can see that there's a relationship between the size of the summer surge as well as the extent of vaccination, and it's unfortunately or just realistically linked to partisan voting trends. So we can see that policies statewide, as well as misinformation, as well as other access problems, have led to significant gaps, which have meant cumulatively significantly more cases in places like Georgia and nearby. And I also want to make the point that this is not just cases. If we can go to the next slide. Here, there's a relationship that I hope you can see between essentially cases and then cumulative fatalities. And there's a very strong, nearly one-to-one link here in terms of this correlation, where those that are at the highest in cases are also near the highest in fatalities. Yes, there are outliers, but it's very strong. So just in case you've heard from folks, this Delta wave is just cases, that's not true. Cases mean hospitalizations, unfortunately mean fatalities. And we have continued to see cases with some delay lead to peak levels of hospitalizations, and in many cases near peak or post, or even higher than previous highs for other waves in terms of fatalities in states. Next slide. Greg, I don't know if you can go to the next slide. Great. And so if we look then at Georgia and in Fulton County, I think you can see quite apparently that the magnitude of this particular fourth wave, the first wave was significantly under ascertainment, improved over time, but it is a very strong wave that is, as you probably have read, whether in AGC or in other outlets, leading to strains on hospitals throughout the state, high levels of fatality, and that applies both statewide and here in Fulton County, which is the context for many of the reasons why, in light of the chances of increasing spread and the issue with the absence of a vaccine mandate going back into the spring, that so many of us were concerned about reopening in the event we started to see case surges and we didn't have the right kind of NPIs as well as the right vaccination requirements in place. So again, to highlight this, we have national trends being mirrored in the Southeast, being mirrored in Georgia, and then to the next slide, I also want to point out that when we try to use some standard methods to use relatively recent case counts to estimate positivity, we have different assumptions that we make here in terms of under documentation of cases. The red is about 3 cases that are undocumented for every one that we document, otherwise 5 to 1. And what you can see is that in Fulton County, we currently estimate about a 1 to 2% background rate just in the county as a whole. And obviously, we're not ascertaining most of those cases, but that gives you some sense that even for individuals who may not, we're trying to infer and trying to reduce spread on campus, but we are part of a community, we're embedded in it, and the community as a whole is undergoing obviously an increased surge. And that also means in practice that if we look at a particular group, we get into kind of coin flip territory for medium size. Greg said 20, and it depends on the numbers here with biases, but we're getting into kind of coin flip level odds that one or more may be infected. And I think anyone who's teaching classes in person, once you get into the 30 plus, you probably have known of a case. Now maybe that person is then isolated and you don't know of one for a little while, but you're certainly going to hear an aggregate of cases. And at any moment, once these groups get large enough, then there's obviously a risk. And a key point here is how do we, if we just go back, how do we make sure that that one doesn't become many? And that I will try to build towards some of the arguments that Greg has already laid out, and I'll perhaps just emphasize them again and also talk about ways in which we haven't. I think we all know we don't have all the tools and all the levers that we would like to have at our disposal this year, particularly in light of Delta and particularly in light of the fact that there are levers that we do have this year that were not even available last year, right? Last year we didn't even have vaccines as an option. We do now. And Sally will tell us about some other efforts too to improve process engineering. We're using some, but not all of the available levers. Next slide, Greg. And so in thinking about where we are now and what we can do about it, I think it's important to point out that we are in a better place because of the interventions that are under our control, and that doesn't mean we're in the place we would like to be. Both things can be true at the same time. This is some comparison of what is called the UGA dog check, which is essentially a similar surveillance program, not as large per capita. I believe, Greg, it's about 3 times smaller. I think that's what we estimated last year in terms of per capita testing rates. And you can see they have reached and surpassed their high already at UGA. This was last week, above 5% positivity. And I can assure you that 5% is a very high level of positivity for a random program. That is a very high rate. We don't want to be anywhere near that because that says even groups of 10, 15 essentially are a coin flip chance that someone's infected, and it's not possible to scale up contact tracing and isolation with that large of an incidence rate and in a community. So worse alternatives are possible. That's hardly relief or comfort. So let's talk a little bit more about what's going on. Go ahead, Greg. So in order to try and reduce spread, and I know that we've talked about R0 here before, if we think of it as the product of infections per time, which Delta makes it worse, times this infectious period, there are all sorts of ways in which we can try to reduce it effectively. We can do this, and I think we argued last year, and you could see this in practice, that testing is identifying people and removing them from circulation by isolating them, potentially even with contact tracing as a follow-up, to reduce the number of infectious individuals who might interact with others. And if we do this at scale, and again, as you know, we don't have a testing mandate either, but last year we showed that there could be a high enough compliance that we start to remove individuals who then are not in circulation, and that effectively reduces the chance that that one case becomes many, and we're able then to continue to pull those positive cases out. We also want to reduce the contact with the susceptible. And last year, when we started, there were no vaccines available. And for the vast majority of us, we were immunologically naive. This year, vaccinations are available. So I'll just say it clearly now. I'll reiterate this point in a few slides. In my view, there should be a vaccination requirement. There are hundreds of other colleges which have implemented them. Doing so would reduce the probability of contact with an immunologically naive individual and also help that individual not only stop from them infecting others, but also reduce their chance of severe disease. So that's another lever that we have, and we'll talk a little bit more about how effective work last spring has helped us now, but it isn't complete. And then finally, in the event that there is that infectious individual and there is a susceptible individual, how do we reduce the probability that that contact, whether it's in a shared space, indoor space, or classroom, transmits? Process engineering and PPE are become our last line in this sort of Swiss cheese-like analogy of ways to stop spread. And again, to make it clear, in my view, we should have mask mandates on campus like we did have last year in indoor spaces. And that would be particularly important in interface spaces in which people of different ages are mixing and maybe an increased risk of severe disease. And the other thing that we have going for us potentially is process engineering. And that is something that there's been a larger emphasis on this year. And for that, I'm going to hand it over to Sally to talk about some of the innovations in that space and what's going on in air quality. Sally, you want to take it away? So I think you may be muted.
I'm unmuted. Can you hear me?
Now we can.
Okay, all right. So I'll just give a quick introduction of the air quality monitoring work that we have been doing actually since last fall. So I want to emphasize this is really a huge effort of a large team of graduate students and undergraduate students together with staff from Georgia Tech EHS, like environmental health and safety, and also facilities and management. Slide, please. So what we have done is that we have deployed a network of air quality sensors in indoor spaces on campus. A lot of these spaces are in the classrooms. So these are called Quantaq air quality sensors. So if you see a little shoebox in one of your classrooms, please make sure to leave them plugged. So these air quality sensors, they can measure different pollutants in an environment, including CO, CO2, and nitrogen oxides, NO, NO2, and also ozone. And another important parameter that was measured was the particles. We call them PM, which is also called aerosols. And over the course of the pandemic, airborne transmission of the disease have been recognized as an important medium for how the virus got spread. So in terms of PM, the way that we look at it is PM1, 2.5, and 10. And the number next to PM just designates the size of the particle that is measured by this device. So PM1 means all the particles have a diameter smaller than 1 micron. And so for reference, our diameter of our hair is about 50 to 70 micron, just as a reference. And PM2.5 and then PM10 and so on and so forth. So we collected these real-time cloud-based data to aim at improving air quality to make sure that the classroom environment is safe. And we also have evaluated the effectiveness of different air cleaners. And basically these data that is cloud-based and real-time allow us really make data-driven decisions on the ventilation and filtration and air cleanness, just to make sure that we maintain a low level of aerosols in these environments. Next. So these are just kind of an example data for you to look at. So the y-axis of these two figures plots the concentration of these PM1, PM2.5, and PM10 in microgram per cubic meter. And the left-hand side is data from spring this year, and the right-hand side is just really recent data after fall semester started. So a couple things to mention in these figures. So you can see that PM1, which is the lighter green, and PM2.5, which is the medium green, they're always pretty low at a few micrograms per cubic meter. So these are pretty low levels. And you can see that the PM10, which is the darker green, it actually spikes. And these spikes actually correspond to when the classes started, and it kind of decays away, when the class ends. And this is bigger particles. So PM10 are particles with diameter smaller than 10 micron. So these are bigger particles, likely just come from resuspension of dust when the students and instructors walk into the class. And just a quick note is that these measurements measure the sum of all the particles in that room. So we do not differentiate between biological or non-biological particles. It's the sum of all particles in that room. So how do we use these data to kind of make data-driven decisions to make sure that we are in a good ventilated environment? So once the students and the instructors leave the classroom, the aerosols and the PM will decay, and the CO2 will also decay. So based on that decay rate, we'll be able to estimate our ventilation rate in that classroom. And we want to make sure that every classroom is really well ventilated to reduce the chance of transmission. And overall, we really need to take this blanket approach to do everything we can to reduce the transmission in these indoor spaces. And this has been mentioned before. I believe that we should have a mask mandate to make sure that you're not just protecting yourself from others, but you're also protecting others from you. And based on these data, we're also making sure that we are having high enough ventilation rate in these classrooms so that the air is exchanged frequently during the class and after the class. And if you're in a classroom that you have windows that you can open, so hot in Atlanta, but you could open the windows to try to get the windows open. And Georgia Tech and EHS and also facilities also have implemented really high efficiency filters for all these buildings. And then if you're in classroom, you see that there's an additional air scrubber that is now being implemented in all buildings also. Next, please. And this is just our last slide showing that in terms of the air cleaners. So now if you go to each classroom, we already have an air scrubber that is implemented in each of these classrooms. And there are many types of air cleaners that you can find in the market. So just a little word of caution is that not all air cleaners are made the same. So there are a lot of electronic air cleaners, and we test a number of them. And one of the cleaners that we tested is called a hydroxyl radical generator. So hydroxyl radical is a radical. So what happened is that when we turn on these air cleaner, in the process of cleaning the air, the hydroxyl radical actually react with the compounds in the room and make more pollutants. So the yellow highlighted area is when this device is turned on. So instead of reducing, the VOCs and gases and particle pollutants in that room, this device ends up actually increasing more pollution in that room. So just a word of caution, and the portable air cleaners that we have deployed in the classrooms now is a HEPA filter with no additional, chemistry that will be induced. So, this is pretty effective because all these HEPA filters has greater than 99% of efficiency in reducing the particle. And based on all these data, we'll make decisions on whether there's more additional portable air cleaners that need to be deployed in any of these classrooms if we are seeing that some of these classrooms do not have high enough ventilation. So that's all I have to share. Thanks.
Great, thank you. So the slide right before Sally described some of the innovations in terms of air cleaners, I mentioned these different levers that we have. And now I want to go through some of the things that we haven't done. And Sally, you mentioned mask mandates, and I think we all know that there's variable mask wearing, both in terms of the right mask, wearing the right mask, as well as having the right number of people, meaning all, wear a mask in the classroom. And that is a goal. I know I can see already perhaps the largest number of Q&A questions, and I think what we're going to have to do when we get to that point soon is to try to address some directly in the chat, and Todd and Jess can help us filter and talk about some recurring issues as well. But I did want to point out that the approvals and ultimately now the FDA full approval, the emergency use authorization followed by FDA full approval for Pfizer was based on the efficacy against severe disease. And that means that we have a lever this year at our disposal that hundreds upon hundreds of other institutions have utilized, and that I recognize varies by state and is strongly correlated with the last presidential result, and in fact correlated to some extent with gubernatorial races. But it is not monolithic in the sense that Indiana University and the state of Indiana have in fact made vaccination requirements, and as anyone knows, students who come to Georgia Tech already have vaccination requirements for other infectious diseases that haven't stopped the global economy and caused over 650,000 deaths in the United States and millions worldwide. So can it be done? Yes. Should it be done? Yes. Has it been done? No. So next slide, we'll talk about what we know. So this is a bit of a complicated slide, but I do, because I can see in the chat already, there are questions about what we know, and I think there should be hopefully more data transparency. It has been harder based on some governor executive orders. Let me try to tell you what I think we know. That in early January, if we just looked based on how many cases were reported, we had a low number of aggregate infection. And Greg and I, working with Matt Collins and Christopher Haney, colleagues at Emory and Johns Hopkins, initiated a saliva-based antibody survey in February 2021, which showed, again, it's not completely unbiased, and it was random participation, largely students, some staff, and researchers in IBB, about 15% had evidence of antibody. And yet, in the spring, as you recall, we had a rapid transition and a very effective vaccination program run out of a hall on campus that was quite smooth, overseen by Dr. Ben Holton from Stamps. We received about 36,000 vaccines, and as of May 5th, had administered about 29,000, 16,000 unique individuals, 13,000 plus completed 2, implying had received the full benefits of protective immunity. This is consistent with a totally independent follow-up antibody survey. We had about 370 participants, and 75% had evidence of antibodies, either through infection or vaccination, or sometimes both. If you go to the next slide, you will see, though, that in those intervening 4 months, yes, it went up, but by about 2,000 on campus. Now, it's not to say people didn't utilize other means off campus to get vaccinated. Surveys have been done of students, so I think that these numbers, and let's go back to them, Greg, because I think you mentioned high numbers of vaccine coverage on campus, and I think I agree with that insofar as the population immunity of students is probably very high. I have less confidence, and unfortunately at the moment, I don't have hard data. I don't think any of us do, though I would like to see it, with respect to vaccine coverage among staff and to some extent faculty. Unfortunately, Georgia has lagged, and we, despite all the valiant efforts of Ben Holton and many others to make it as easy as possible, I mean, incredibly easy and efficient to get vaccinated, I expect that staff levels, to some extent faculty levels, will be more of a reflection of the state levels. So even if we've done a little bit better than that, it means that there is a significant gap in vaccine coverage that is eminently coverable and fixable. They are available to all. They're safe, easy, and effective. So just to give some sense that we do have hard evidence. Even in the spring, we had a sense that the vaccine push really had rapidly switched the immunological status of the community from one that was largely immunologically naive to largely, especially amongst the students, had some prior knowledge in an immune sense of this virus, and thankfully largely through the vaccine program. Can you go to the next slide, Greg? So I'm going to give some takeaways here, and hopefully that can be a gateway. We're now up to 57 questions, and we haven't given that many answers, so I think we're going to have to try to address some. And also, I'm happy, I'm sure Sally, Greg, we're all happy to take questions afterwards, but we'll try to go through, and if it extends a little beyond, that's fine. Delta is a formidable challenge. Abilities to control and prevent its spread have unfortunately been made much more difficult by BOR decisions to limit public health safety measures on campus. At present, there is no indoor mask mandate. There's no vaccination requirement. That is not good news. On the other hand, Georgia Tech's testing program, investment in air quality, high vaccination compliance through this entirely voluntary Spring 2020 initiative has blunted the impact of spread. Keep in mind, in terms of action items, with about a 1 to 2% positive, once you get into the 40 or so group, classes about that size, a little above or a little below, it's basically even odds that one or more are infected. And I hope that's a reminder to students and to faculty and staff to wear masks indoors, and particularly in the classroom setting and in other places where you're gathering in groups, because they can lead to rapid spread. Large scale, what's called overdispersion, or fat tail distributions, super spreading has been associated with COVID-19, and indoor gatherings are the predominant route, especially through this airborne route. I also think that one should expect to be, in some sense, exposed in coming weeks, meaning that there's a chance that someone around you may be infected. If they're wearing a mask and you're wearing a mask, then the odds go down. If you're outside, they go down. If you're distanced, they go down. If you're unvaccinated, the odds are far higher that an exposure will lead to infection and potentially severe disease. And you can look at 1,000,001 documentation of the fraction of individuals in hospitals who are unvaccinated. So if you're listening and unvaccinated, I'll say in a moment, the time to get vaccinated is right now. Finally, just to make another plug, the testing program, it works, but it is synergistic. So if we use these other measures, and particularly when we get to below 1%, we can get to a point where the pace, and I know there are questions about pace, of testing with tracing and suggestions on how to improve that. I think there are many good ideas, especially about going directly into classrooms and informing folks as far as is possible so that people can take action changes in the classroom and use other modes. But we can only leverage that if enough people get tested regularly. And we are recommending about once a week. And if we can therefore pull out some more of the positives soon and get to a lower number, then we can use the available tools to continue to test, identify, and reduce these large scale spread events. And with that, I'll hand it over to Greg.
Okay, thank you very much, Joshua. I'll just make this, and Sally, fabulous presentations. Really excited. I'll just make a few quick points in closing, and then we can go to the questions. So, first one is we've had actually 950 classes with more than 10 students having positives. And I don't know what fraction of all classes it is. I think it's probably at least 80%. I know in biology, we've got almost all classes have had positives. And this is a percent positive cases per class of more than 10 students. So it's the mean and median are around about 3%. A lot of that is because it's one person out of 50 or something. So on the right-hand side is the relationship between class enrollment and the percent positives for those classes with more than 10 students. So, if it's more than 10%, the black line is just one case. The gray lines are 2, 3, 4, or 5 cases. But you can see it's very consistent with our estimate of about 1%, 1.5% per week. So we had 2 weeks. So it's getting up to about 3% overall. So bottom line is almost every class has had a positive in it. And that's what faculty are so concerned about, and that's why we're asking students to just do the right thing and wear a mask and be cautious. But we know the vaccines are working. As we look at the numbers on campus, the only way we can square them away is if we realize that actually a lot of the people that we know are unknown status actually must be vaccinated. And we don't have accurate data on true vaccination rates. But we can guess that probably about 85% of the community is vaccinated. Again, we don't know how many unvaccinated are not testing. We suspect a reasonably large number, and that's the biggest limitation to our modeling. But the good news is that we have a very largely vaccinated population, and they're really controlling. Otherwise, without them, last week would have been 2, 3, 4% sort of numbers you're seeing at UGA. And then Joshua showed a slide there that said that, last year we got it down to 0.3, 0.4%, which is 3 times lower than UGA was seeing. It's because we had a program that was so comprehensive. Instead of testing 500 a week, we were testing, 5,000 or 10,000 a week. And that's what allows us to capture that 1% and take you out of circulation. The sooner we can do that, the sooner we can get it down to this safe, live, work, learn environment that all of us really yearn for as soon as possible. So if we can get there, and I really think the data supports that we will get there again fairly soon. I could be wrong, but I'm optimistic about that. Then I think the sooner we can get there, the more we can get back to a normal-ish sort of life environment. I do want to just say as well that the lab has been overwhelmed. We didn't expect this. 2 months ago, we were even debating as to whether or not to have a surveillance program because things were going so well. They've been overwhelmed, short-staffed because we weren't ready. People have done just heavy lifting. We're doing something like 3,000 a day right now. That also put a lot of pressure on the reporting. That's getting fixed thanks to Mike Shannon and his teams, Brian Liu, getting it together. So thanks for your patience. Some of the reporting has been a little bit slow, maybe 48 hours turnaround, and some of the items on the dashboard have not been exactly accurate, but we're getting there. But I can tell you that the trend is in the right direction right now. It's around about 1% and hopefully going lower. So keep at it. Appreciate everything you're all doing. We're doing what we can to keep us safe. So I'll stop there and hopefully there's a little bit of time for some questions, Todd.
Yeah, so thanks to all the panelists for the presentations, and thanks to everyone for their questions. I've been looking through and trying to sort these into categories. I think that's probably the best way to handle in our limited amount of time. So, Greg, there are quite a few questions about the representativeness of testing. How do we know that we are testing everyone on campus? Do we make efforts to test representatively on campus? And maybe a corollary of that is, do we have an idea about where transmission or when transmission is happening on the campus?
So I'll have to stab at that. So, I spent a few hours last night looking at some new data I got yesterday. And so we had about half the positives in the surveillance program, and no, on campus overall, were from vaccinated people, and about half were from unknown status. And there was a little bit higher rate. It was about 1% in the first and 1.5% in the second. And that's just not consistent with a vaccine that's sufficient. So I crunched the numbers, and it turns out that we can only get to a vaccine that's 70 or 80% efficient if you assume that something like 85% of the other category were truly vaccinated. So that's good news. It implies that we've got a very, very large vaccinated portion. Some of those, of course, will also have natural immunity because they've had it before. But the kicker is that we're only sampling people who test. Okay. Now, I would expect a bigger caseload at Stamps if that community was large. So Stamps did not have a massive jump last week either. Now, of course, people may be asymptomatic or very, very mild symptoms and not reporting. There's really no way for us to know. But I think parsimony suggests that we actually have a very large vaccinated population, and maybe only a few thousand on campus unvaccinated who are certainly at a 5-fold higher rate, and they're putting themselves at higher risk. So the second question was?
There's the question of also, are we testing comprehensively? And I'll just point out that we know we are not with respect to under testing, whether in certain residence halls, in Greek houses. And that was something that last year we put a lot of emphasis on identifying clusters, moving in rapidly to increase testing. We haven't seen necessarily an explosion of cases in Greek residences, but we're also aware of severe under testing. So this is going to be a challenge for the campus community, the absence of a mandate for testing, that working collaboratively is the only lever we have right now. So I think we definitely want to see more testing, and trying to work on comms to get that up is going to be key. Otherwise, we remain somewhat in the dark about certain spread in certain sectors of campus.
Yeah, thanks, Joshua. So the other aspect was, where is the transmission happening? So interestingly, this year we've not seen any massive, any really strong clusters. Okay, so one of the residences had one floor in a residence had 4 or 5 cases a few days ago. But aside from that, it's pretty much spread throughout the Greek and the residences and off campus shared rooms as well. And we'll be looking into why that is over the next month or so, but I suspect it's because of mixing vaccinated with unvaccinated sort of spreads it out. But I doubt that there's been a lot of transmission in classrooms, but we worry about transmission to faculty enormously because they're at much higher risk. You know, as you get up to 50, your odds of hospitalization go up to 5 or 10%. If you're over the age of 60, they're much higher than that. So, and death, you know, over the age of 65 is much higher. So we need to protect the faculty, which is why we worry about classrooms. But my guess is most of the spread is in parties and in large gatherings and coffee shops and things like that where people take off their masks. But that's just a guess.
Okay, many questions about the estimates of vaccinated individuals on campus, and so could could one of you just say a few words about how this has been determined? I mean, as far as I know, this is determined through surveys.
Yeah, so there was no mandate for people to report their vaccine status. So we know for people who had it last year, they're in the records, and we know that some people reported. But as I mentioned, about half the people testing, it's an unknown status. But we can infer that the majority of them are actually vaccinated. For those who don't test, we have absolutely no idea. So yeah, that's a limitation. We just don't know.
I'll only
Sally,
say that on. Yeah,
go ahead.
No, go ahead. I'll hand over Sally.
Okay, Sally, there are a few here for you. One that you probably hear quite a bit. Classroom windows open or closed?
Yeah, that is a good question. I think a lot of windows on campus cannot be open. And the one question about opening the window is that how would that affect the whole ventilation of the building? So I see a bunch of questions about, like, are we supposed to buy a bunch of portable air cleaners? So one thing to clarify is that those are additional measures. So every building, every room is being ventilated, and every building and every room has already a filter, more than one filter in that building. So at the beginning of the pandemic, Georgia Tech EHS and facilities already outfitted, upgraded all the filtrations in those buildings already. So I would say that if you are in a room or building that actually have windows that can open, one thing is potentially to also check with EHS to see if opening those windows will affect the ventilation in other classrooms. Obviously, opening the window in your classroom is good for you and students in your class, but it might potentially negatively impact other people. So I think that is really building by building and room by room cases. And the comment that I made about wearing masks is just that is the source of all the respiratory aerosols is, and then that is one thing we can reduce, emitting those into the room, to start with.
Thank you, guys. So similarly, many questions about Georgia Tech's efforts to trace contacts, and I know this is not the main emphasis of this town hall, but could you say a few words about how Georgia Tech is contact tracing? The bits to this that I can add are, so many questions, for instance, from faculty, like why am I not notified when a student in my class tests positive? And as far as I am aware, the reason that you are not notified is because you as a faculty member were not identified as a close contact. What we learned today in a campus-wide meeting of chairs and deans is that a new question will be added to the questionnaire from contact tracers, which says something like, should the faculty member in your classroom, if you've been attending classes, be notified that you've tested positive? So now that question about the notification to faculty will be included. We've also heard that because the Institute has not is not physically distancing in classrooms right now, that it is much more difficult to trace contacts. So it used to be that perhaps the contact tracers needed to reach out to 4 or 5 folks, and now it is in the 20s sometimes. Greg or Josh, do you have anything to add?
Yeah, I mean, I think Ben Holton and his team are doing, tremendous work. They've got a team doing all they can, but they've got 2 limitations. One is that, there's 950 classes, most of which have had positive, so there's just no way they can contract traced all of those. And of course, we don't have seating plans in most classes, so you don't know the people who are closest. And Sally may have a comment on whether or not proximity in a classroom really matters. But that's a big limitation. They're doing what they can with a fairly small staff to do the contact tracing. In terms of informing faculty members, my understanding is it's a HIPAA interpretation, so it's a violation of health privacy rules for a professor to be told that somebody in their class has been positive unless that person reaches out to them. And I've had students reach out to me at various times and let me know. I appreciate that, but you're not really supposed to transfer that information to your class either. So it's about health privacy. Everything's a balance. Personally, I'd like to see it, but it's not allowed.
Okay, so
do you have a thought on proximity?
Yeah, so maybe I'll comment a little bit on that. So aerosols are small particles, and they actually stay suspended in the air for a long period of time. So, if I'm just sitting next to you or I'm farther away, eventually the aerosols will reach out to you because they stay suspended for a long time. The main thing here is the ventilation. We want to get them out, right? So that's why where the air exchange rate and the ventilation that we are trying to calculate for these classrooms, are very important so that we can actually know what is the air exchange rate in these rooms. We want to increase that, so that any aerosol that got emitted into the room can be exchanged out, as soon as possible.
Okay, so we're at 5 o'clock, and I think what I want to do is ask a question that allows each of you to sort of wrap up. Many of the comments and questions, I think, have to do with what students, faculty, and staff can do to express their concerns about the current situation on campus. And maybe just quickly to review, Georgia Tech does not have the power to institute mask mandates or vaccine mandates or testing mandates. We are governed by policy set by the University System of Georgia, which is a system of 26 other institutions, and policy is set uniformly across. And so the question to the panelists, we produce these data. These data are very striking and informative, but how can individuals have their say or make the case to the Board of Regents or to the USG?
Joshua, do you want to start?
Sure, I'm happy to start because I think I've been public about this. We should be in a different kind of place right now. There are levers available, including indoor mask requirements, vaccination requirements, and other ways that we could use testing that would be of benefit to the health of the students, staff, and faculty, and also be easy to implement. We know how to do it. And so I think there's a recurring set of issues here that the BOR has made decisions that are not grounded in the best science and options available. And I recognize that we are trying to walk a certain line in doing the best we can with the levers and tools we have, while at the same time advocating for better tools. And so to the extent to which you communicate to your representative, to the BOR, the leadership, of what you expect on this campus, what do you expect out of the university system as a whole, I think you should do so. There's a lot of questions here in the chat in which I would say, I agree. And yet, even if I agree, I still don't want to do something given the options we have to try and mitigate. And that was our attempt last year. Now, last year, we were in a very difficult situation, but the testing program worked. It worked effectively, even in a moment in which we did not have vaccines available. The reality is that the large-scale vaccines have made a very big difference in reducing the opportunity for this disease to spread. So I guess I'm happy to follow up, and in fact, if folks want to email me or Greg or Sally to talk about specific ways, but it's clear that if we don't move quickly to get lower incidence, then many of the levers stop being as effective. The contact tracing becomes too slow. The reporting of tests becomes too slow because we have too many positives. So I think there's an urgent need now for voluntary steps, while at the same time moving quickly to try to make mandatory steps universal. And with that, I'll hand it over to my colleagues.
Yeah, so last year we were in a similar situation at the beginning of the pandemic that we don't have a mask mandate. And there was this petition that I think a large number of the faculty and students signed a petition, and eventually we were able to get our mask mandate. And I really concur with what Josh said, is that within the domain or restrictions that we have, we're doing all these additional measures to the best we can to make sure that the transmission is low. But I do feel like hearing that there is a case in every classes, I think we are at a point that we need maybe more actions to really request, this is my personal opinion, to request of the mask mandate and then vaccine mandate. And I also agree a lot of the questions here ask the same questions, myself.
So thanks, guys. I think a mask mandate is achievable. I think if the students really got together and really pushed for it, and faculty have pushed, but I think a student push would be great. I'm worried about the next 2 or 3 weeks. I think if we get through those, we can get this low. So part of that is just peer pressure. If you're in class with a group of 3 or 4 friends and one of them doesn't have their mask on, just gently ask them to put the mask on. To create a culture of expectation, I think is great. We can push for the mandates. A vaccine mandate, whether or not that's advisable, it's not going to have an impact for another few months because it takes that long for it to have an effect. So we need that long-term, very, very high vaccination rates. But in the immediate future, what you can do is to just encourage your fellow students and staff members as well, because some faculty are just as culpable, wear those masks. The final thing I'd say is that I think we are very lucky here at Tech that we've had leadership that have backed this program. A lot of ire goes to the Tech leadership, but as Todd and Joshua both said, that the constraints are from above that, the Board of Regents, USG level. And, I can't speak for our leaders, but I can tell you in my conversations with them, they're very, very supportive of all that we're doing and to try to advance just sane and sensible control measures. And this program is unique in the USG system. It works. It will continue to work. I'm pretty confident about that. And Frank Neville has put multi-million dollars at our disposal to make sure it happens. And the provost and others are just doing what they can in a difficult situation. So, but I want to end up on a really high note. I really think we're at a good. 3 days ago or 4 days ago, I was not sleeping. I was really worried, but I just feel like we're headed in the right direction because of everything that the whole community is doing, coming together like they did last year. So it's just keep it up. It's great.
Can I before you end on a high note?
I think we have. Joshua, come on. Now.
Right. I just, for those who are listening, I think that we have a tension here of trying to do as much as we can with the levers we have available, while recognizing that, if you out there listening to this, if you feel we're not in a good place because we're missing these major things, that is true. So I think we're trying as hard as we can to hold 2 thoughts in our mind, doing the best we can with the levers at our disposal, this tech-driven, meaning generated here at Tech, large-scale asymptomatic surveillance that has worked last year and is continuing to show promise this year, additional air scrubbing and so on, while at the same time knowing that we are not using other methods that we could be using. The moment for them to have been implemented is the past. The next best moment is now. So I would happily talk to folks who would like to push those larger issues. And we hope that the information we gave you today continues to reinforce why the science-driven policies of mask mandates indoors, vaccination requirements that work, and other increases in testing would all be to the betterment, not just of Tech, but to the USG system.
I think that's a really good place to leave it. It's 5:10. I want to thank everyone again for attending, and I want to thank our 3 panelists for the frank discussion. I'm going to stop the broadcast now, and so I'll just say to everyone, have a great evening.